Alright guys, so welcome to Subu Medicine, and today we'll be discussing about the trauma stress related disorders. Okay, so based on the DSM-V book, they categorize those disorders in this following pattern. So you have a PTSD, which is also called post-traumatic stress disorders, acute disorders, adjustment disorder, normal bereavement, we'll talk about this one too actually here, reactive attachment disorders, and disinhibited social engagement. So 1, 2, 3, 4, and 5, these 5 are based on the DSM-V book, okay, that falls in trauma related disorders, all right, not the normal bereavement. This does not fall there. I just add there because we're going to talk about that too. So whenever we talk about this trauma stress related disorder, what is this? What is trauma? Let's talk about that, right? Any sort of, let's say, life-threatening or let's say catastrophic event that happens and that induces stress. Look, that's sort of a trauma, okay, life-threatening. The issue is trauma, and that gives you disorders where that impairs or dysfunctions the normal functions of the person, all right? So the trauma could be, the trauma could be like anything. Like oftentimes we know that the trauma is, oftentimes we get to hear, it is a, let's say, sexual abuse, all right? Or simply you can say this is as a rape, that one. And also this is very common, happens, let's talk about, in the military, like let's say military, or like soldier battle. All right, military combat, we'll say military combat here. Or not only this, sometimes the trauma could be result of, let's say, you saw, house burning, let's simply say house burning, all right, house burning. Or let's say sometime, not only, look, this is like sexual abuse, military combat, house burning. Maybe this is a direct contact. Maybe you personally went through that, Or sometimes what happens is that this, we can say this is more like direct, okay? But sometimes you can have it through, let's say, witnessing. Let's just say that, you saw someone getting abused, okay? That can also cause you the traumatic events, all right? And not only this, or you just like, not only this, but you also heard, okay? Heard, or hearing. Hearing also can actually cause this trauma. Specifically, the one I'm talking about right here is PTSD, all right? All of this could be the, causes of, giving a diagnosis with PTSD, all right? It's a very important concept. So, it's usually, okay, these are life-threatening conditions, like catastrophic, right? And that, causes stress to a person. And the way you do, the way based on the DSM-V, the way you do diagnosis with the PTSD is, because that's the first thing we're going to talk about here, that's what we'll be talking about. And what is it is that, it's not that the person's went through a trauma, okay? We all go through a trauma, okay? When you give a diagnosis, how they are responding to trauma, usually it has to do with over expressions or over respond to the event that has been occurred to them. So whatever the trauma is, it could be the rape, it could be this any sort of abuse, all right, or let's say seeing someone getting burned, or let's just say, or in the military combat, a military soldier, okay, anything, that influence or that triggers your memory, and you overly expressed to that event, and that causes what? That causes this following event. It's very important that you remember this, all right? These are classical signs. You would have a recurrent, okay, let's just write on here. Recurrent, okay, or let's just say recollections of that event. What does that mean? All right? you have a recurrent, you keep thinking, that's keep coming to your head, and the recollections of the memory in a way that, you started having what? You started having, let's just say, nightmares. Let's just say nightmares about that, about the event, or you can even have a flashbacks. Look, flashbacks of the event. Recollection. That we call this as intrusive memories. Let's just say this is a intrusive memories. All right, it's within yourself, intrusive memories. All right, and that gives you like this nightmares of that event. You have these flashbacks. All right, you have that, and not only this, you try to there's avoidance. What is this? This avoidance has to do with this. Look, in order to give a diagnosis of PTSD, you need to have the recurrent recollections of that event, of that trauma. That sort of gives you this intrusive memories. You have this like nightmares, or these are flashbacks. Or you tend to have sort of this involuntary or recurrent memories. Let's write involuntary too, because you don't have this. You're not controlling over this involuntary, right? And obviously avoidance, meaning that you try to avoid that stimuli, meaning that if someone is, let's say, got sexually abused, then what happens is that the person who was abused, if they see that person who abused them, they tend to what? They tend to avoid them. They tend to avoid the stimuli. That's what this avoidance means, okay? They need to have these two features, and on top of this is very important. The time framing plays a very important role. Finally I talked about the time frame. You need to have these problems at least, look. This needs to be, look, let's just say, it has to happen for more than 1 month. Okay? You cannot call, if this event happening, okay? This is event happening less than 1 month, and you cannot call this as a post-traumatic stress disorder. Okay, there's something else we have to call, but that is called, we'll talk about that actually. If it's less than 1 month, then we call them a acute stress disorder, ASD. This one, the second one, all right? But again here, look, in order to give a differential diagnosis of the PTSD, you need to have a problem that is lasting more than a month, more than 1 month, okay? And they need to have these following symptoms: involuntary, recurrent, or recollections of the event, okay? And, with the recollections of the nightmares, or usually they have traumatic, let's just write down here. They have this traumatic nightmares, they have this flashback, okay? That's what they have. And on top of that, they have this avoidance, all right? That's what they have. And obviously this is happening more than 1 month. They need to have this, at least 2 of this, and on top of that, people who have, let's say, PTSD, they also show other symptoms. Let me write it in different color. What are those? Look, those people have they're vigilant, they're hyper vigilant, which basically means they're always scanning, all right? That's what they are doing, hyper vigilance. Other one, there's also sleep disturbance, like they have the sleep disturbance. Some people, they have difficulty following sleep, okay? They can't sleep, okay? That's they do have that. You could have let's just say, lack of concentrations. They tend to have a lack of concentrations, all right? Motivations, lack of constant motivations. They tend to have guilt too, excessive guilt. And look, let me write down here. Not only this, they have basically, they have something called, let me write in different color here. You have a repetition compulsion. What is this? We'll talk about what that means too. Repetition compulsion, obviously they will have what? Fear, right? Fear, 10, what are these? Look, people have traumatic events, right? If they're going to traumatic events, obviously they have a problem with the fear, right? And especially when they see that the trigger point, that's what the fear is there. They tend to be angry too, okay? So these are the, some other symptoms, like the people who have PTSD, people have it. Now, remember we said that, but all the symptom has to last for more than 1 month in order to give PTSD, okay? But one more thing, that if any symptoms happen, all the symptoms happens, let's write down here. All the symptoms happens, let's write it down here, okay? All the symptoms happen, which is less than, look, if it's less than, let's just say less than 1 month. Less than 1 month, right? The onset of symptoms, okay, the onset of symptoms, let's just say, happens within 3 months, okay, within 3 months, but then resolves in 4 weeks or less than 1 month, and they have all the symptoms, look, recall, involuntary recall reluctance, and they have nightmares or flashbacks, they have this avoidance, and then they have hypervigilance, and all of them, then we call them a acute stress disorder. This is how you can actually do differential diagnosis with PTSD and ASD. It is very important that you know, all right? It is very important because it's a time frame that plays a very important role. Again, acute stress disorder, that lasts about 4 weeks or less than 1 month, okay? When it comes about the PTSD, if this sort of a symptom that goes for the more than a 1 month, then based on the DSM-V book, we said that's a PTSD, all right? Now, what is the pathophysiology of PTSD? Look, that's what we have to talk about. If you come back here, look at this. You see this is, look, this is my frontal lobe, right? Let's just say this is my frontal lobe. And obviously, let's just say this is parietal here for our case, all right? There's occipital and there's a temporal right here. The problem with this is, all right, usually whenever the traumatic event happens, what causes is that, like if you look at, this is called my cingulate gyri, okay? This is what it calls cingulate gyri. And right below that, there's a corpus callosum is there too. Cingulate gyri is a part of limbic system, right? And then this is, let's just say this is my hippocampus. All right, this is my hippocampus. This is for memory. And this is right here is my, very, very important, amygdala. All right? Now, one thing you have to remember here is that the cingulate gyri is very, very important for what? Let me write down here cingulate gyri, okay? Cingulate gyri and this amygdala, right? Basically, cingulate gyri plays a very, very important role in what? Emotion formation. Look, emotion formations and let's say processing. All right? With learning and memory too. Learning and memory. That's what it does. It also, the cingulate gyri also plays a role in, in sort of feeling sense of, let's just say, sense of security and safety, right? It's an emotional center. It is a part of limbic system. And amygdala, as we know, it is also mood regulating area, right? That's what it is. It's an emotional regulation that happens there. Obviously, it has the formations memory because it also works with the hippocampus is there. It is also like, it also, this amygdala is very important for like response to fear and all. Right? These are some of the functions of the amygdala and cingulate gyri, and it's really important to know because people who have like PTSD, right? What happens is that at least in PET scan, what they show is that there's a hyperactive, like look, there's this hyperactivity of this amygdala. Look, there's an hyperactive activity of amygdala. If there's a hyperactivity of amygdala, that means that the nutrients, the glucose level. Also, there's a high, you see increased level of glucose metabolism is happening. It's because there is a hyperactivity of the amygdala, especially when they see the stimuli, what caused them that, what caused them to have this involuntary recurrent recollections of that stimuli. Then what happens is that, what do you say? You see hyperactivity of amygdala, which basically, remember, which causes the fearness, right? That's why these people have what? A lot of fear. Look, we just talked about this, a lot of fear, okay? And also like anger, because it's an emotional regulatory center. That's what it does. Not only this, look, this amygdala, they also work the prefrontal cortex idea. It works with this cingulate gyri and all that kind of stuff. And cingulate gyri, what? It feels sense of security and safety. So sense of, it's important for, feeling, you give you a sense of security and all. Remember, if there's a disruption on this, what happens to people? People don't feel sense of security, especially when they see the stimuli. On top of that, it is also important for like, alertness. Those cingulate gyri is alternate or concentrations. It helps with that. And people who have PTSD, they tend to be like what? They tend to be not alert. They don't tend to concentrate. Those are also symptoms you get to see. And obviously, in that case, what is happening here is that there is very important relationship between the amygdala with the cingulate gyra and with other sort of like, let's just say, other sort of like, the gyras are present obviously in these gyras are located down here, right? All these gyras are located down here. What happens is that the amygdala have a lot of these connections with a lot of the area nearby, right? It is connected to the, let's say, the thalamus, or it's connected to the hippocampus. So it's because of that, what happens is that when there's a hyperactivity of the hyperactivity of the amygdala, there's an increased level of glucose metabolism happening. That means that there is the problems with the problem with the amygdala itself, because it's working in lot more. There's a hyperactivity of that. That's the reason why there is the hyperactivity of the autonomic nervous system that also happens when these people have the PTSD, right? So it is very important to know the pathologically what is happening here. And remember, the amygdala is part of the limbic system, right? So that's something you remember. And all the symptoms, like look, the nightmares and recurrent flashbacks, this is because amygdala and cingulate gyras that's where they form emotions and memory. That's the reason why, and also they play an important role in, regulating the autonomic nervous systems. And in this case, what happens? They are not able to regulate the autonomic nervous systems, right? And that's the classical symptoms that you get to see, like recurrent, like you're not able to control this involuntary control. And you have all these recollections of this. And on top of that, their sleep centers that is also disturbed. And these people tend not to go to bed or not to sleep, all right? That happens. On top of that, there's something called this, repetition compulsion is there. What does that mean? This is not same as like OCD, obsessive compulsion disorder. Basically, repeated compulsion basically means there is a compulsion, means that we're talking about the behavior. We're talking about behavior of someone. For instance, let's say that, in order to, like for example, if someone has a history of like seeing their house being burned, they may be compulsion. They may try to, like, let's just say, go in kitchen and check like the stove maybe like 4 or 5 times, 6 times before they go to bed. Okay, that is a compulsion behavior that has related with their trauma that happened before. Okay, so that is a compulsion behavior, but that's not same as obsessive compulsion disorder. Okay, that's something I have to let you guys know. But now, after the differential diagnosis between this ASD, let's just say ASD with the PTSD, let's just talk about the other disorder, and that is adjustment disorder. All right, adjustment disorder. And what is the concept of the adjustment disorder? So we talked about this acute stress disorder, right? This is right here. Now this is like number 1, this is number 2. The adjustment disorder is basically, okay, usually this is triggered by, maybe it could be, let's say you went through divorce, or maybe some sort of event, some sort of stressful event, okay? Some sort of stressful event that happens in your life, some stress, like it could be divorce, or it could be you broke up with your girlfriend or something, all right? Or you failed a class, let's just say. Anything that triggers, all right? So what happens is that gives you stress that causes stress in your system, right? But usually this is not traumatic. Usually we say this is a non-traumatic event, okay? Non-traumatic events. Simply let's just say that. So there is the stressful event, okay, which is usually non-traumatic, okay, and that gives you symptoms of, let's just say, like you have a insomnia, all right? You feel depressed, okay? You have a depressed mood, all right? A depressed mood. There's insomnia is there. You have a decrease, doing like activities. So there is like maybe you don't concentrate in school. All right, there's a lack of concentration, there's a lack of motivations, and you feel a sense of guilt. Okay, you have all of this, right? You have all this usually with the non-traumatic event that has happened to your life, and these systems, okay, these problems, again, the time frame, these problems, okay, this usually goes, okay, the problem is usually, the onset of, this has to be like problem that usually goes for like a 3 months, okay? The onset of problems is actually more than 3 months, 2, but not less than, but not more than 6 months. It's very, very important, the time frames. So usually by the 6th month, what about the stresses? What about that non-traumatic stress is there? Usually that gets resolved by 6 months or within the 6th month, all right? That any events, any that cause that goes more than 3 months, and then if it doesn't, let's say if it persists, then it's not an adjustment disorder, okay? In order to be adjustment, no, you're adjusting, okay, with some event that just happened in your life, and usually that goes for more than 3 months, okay? The onset of symptoms, and then, but that get resolved, but if you remove the stimuli, let's say that get resolved by the 6 months, all right? And that is what is called your adjustment disorders, all right? Now, after that, let's talk about the, I'll talk about the normal bereavement a little later, but let's talk about this disorder, which is a reactive disorder and disinhibited social engagement disorders. So when we talk about that disorder, let's just talk about this, all right? Let's just talk about this. Whenever we talk about the reactive disorder, like what is this? Reactive attachment disorders, and we'll talk about disinhibited social engagement disorder. These both are, these are disorders, attachment disorders. Let's just talk about this, right? This is an attachment disorders, all right? This is the common thing. What is really happening here is that, the problem is attachment. Usually this happens in children. When children, specifically between like 7 to 9 months, let's just say this is between like 7 to 9 months, all right? But what is happening here is that, this is the time when the children may need excessive care. They may ask for your emotional support. And if that emotional support is not provided, all right, then what happens is that the children sometimes tend to withdraw from the caregiver, okay? So there is a problem, there's disruptions in the providing care, providing that attachment to the child, okay? And that causes to give you either the reactive attachment disorders or disinhibited, okay, social engagement disorders. You could have any of that stuff, right? And this usually commonly seen in people, like in, let's say, if there's a, let's say frequent, let's say usually say, let's just write down here. If there's a frequently, okay, if you are changing your caregiver, one of the things, okay, and because, why? Because if you frequently change the care, what happens? They are not able to, form a stable relationship with someone, right? So it's because of that, you could get the symptoms. Other thing is that, this oftentimes happens in orphanages, all right? Orphanages. Because in orphanages, what happens is that they have sometimes not able to form an attachment or, let's say, the emotional support care attachment to the caregiver or care provider, okay? That happens easily and mostly often is in the orphanages. Usually you see that, all right? So these are some of the risk factors, okay? Like people in orphanages or let's say daycares, children's, or if there's a frequent changing on your caregiver at homes or you ask at school or at institutions, all right? And that what happens is that causes children to be, detached, or that causes children to be not able to form a stable relationship, or that causes children to be socially withdrawn from the caregiver, all right? And that causes distress in them, and then that's related into what? One of this condition, reactive associated disorders, right? Reactive attachment disorders or disinhibited social engagement disorder. But what is the difference between these two? Is that, okay, usually if you are reactive, look, if this is an attachment disorder, because they were disrupted, there was attachment problem that causes reaction to the children. That's why we call them reactive, and that's a disorder because it is affecting their life, right? That's what happens. And usually these people who are reactive attachment disorder, they tend to be socially withdrawn. Okay, that's what is very important. Socially withdrawn. They don't like to get engaged. with people. That's one of the things. And not only that, they're inhabited in such a way that whenever, let's just say, they are in stressful situation, right? They tend to not to get help. So they're emotionally withdrawn too, which basically means that, let's just say emotionally withdrawn, which basically means that these are the children's, right? What happens is that if they are in a stressful situation, okay, or if something is traumatic, something events are going into life, they tend not to seek out for help, okay? These are the people. These are socially withdrawn, these are emotionally withdrawn. When it comes about this guy right here, these people are, okay, inhabited in such a way, there's a disinhibited social engagement, meaning that, okay, one of the most important things with these people is that, they are socially engaged. Why? Not to the caregiver, but to the stranger. So unfamiliar people. So whenever they say like unfamiliar people, they have like, look, overly familiar. Let's just say overly familiar. Let's just say overly familiar, physical and verbal. Overly familiar physical and verbal contact with the unfamiliar people, or let's just say a stranger. That's one of the classic things they do. These people tend to be not like this. They are less fearful. All right? They tend to, go out with let's say stranger, unfamiliar people, without any sort of fear. That's other sign. Like, they can willing to go out. Let's just say willingness to go out with unfamiliar people or strangers. All right, these are the classical symptoms you see. But here, there's increase in what? Their fear. Okay, this is emotional support. Let's just put it out like this. Okay, socially withdrawn, emotional fear. These people are the one, they have a difficulty like communicating with others, difficulty forming relationship with others. But when it comes about this disinhibited, they tend to socially engage with the unfamiliar people rather than the familiar people. Okay, this is how you can actually do a differential diagnosis between the reactive attachment disorder with the, let's say, disinhibited social engagement disorders. But most importantly, guys, you do have to remember the PTSD though. PTSD is very important, and how you can actually do a differential diagnosis with what is the difference between acute stress disorder versus the PTSD, okay? And one more thing that I do have to talk about here, the adjustment disorders. This is adjustment disorder. Usually this resolve within the 6 months, right? Usually resolve within 6 months. But remember this, do not get ever confused adjustment disorder with this guy right here. And that is normal grief. All right? Normal grief. Or we also call them a normal bereavement. Okay? Bereavement. Same thing. Why I said that is because usually even the grief also, that resolves within the 6 months, okay? It doesn't go more than 6 months, all right? So that's the reason why I mentioned here. So usually it lasts, let's just say lasts for 6 months, let's just say that. And what is this normal grief? Let's quickly talk about this. Normal grief or normal bereavement is when you lose someone that's very dear to you, when there's a loss of someone, right? Loss of it could be a family member, it could be someone that you really love. And that causes, right? That causes, usually, let me just mention this here. Then you go after the death of the person, you tend to go this process of denial, okay? And anger, bargaining, all right? Bargaining. And not only this, there is a depression, all right? And then, obviously, acceptance. Look, usually, when you lose someone, you go by the 5 grief processes, which is denial. That when you lose a person, you deny that maybe the person has left you. You're not willing to accept that even the person, maybe let's say it's your wife, that she could leave you. There's an anger. You tend to start blaming on someone, maybe like it's your fault or someone else's fault because that person left. That person left you, so you started doing that. There's a bargaining, you started bargaining. You would wish that if the person could come back, something like that you would do that. There's a depression, obviously, and we'll talk about that. And then after that, finally, you'll accept, okay? But usually this doesn't go for more than 6 months. Because if this goes for more than 6 months, like for example, especially depressive symptoms, what happens? Then we call them a persistent grief. And if this happens after let's say after losing someone, then we call them a persistent grief, and that can lead into major depressive disorder. All right, it's very, very important that you need to do clinically diagnosis. How do you clinically differential diagnosis with normal grief versus the adjustment disorder versus acute disorder versus major depressive disorders? Is very important, you know that. And here, let me just quickly talk about when we go process of the, let's say, normal grief, right? And I know that I can tell you this because I personally have just recently lost someone someone very close to me, and that's my grandfather. So I know that I'm still in the process of grief right now. But one thing that I am feeling right now, is there was excessive crying, excessive crying, sadness was there, a lot of sadness, crying, sadness. But one thing that I never felt when that is feeling of, let's say, worthlessness or hopelessness, feeling of hopelessness, worthlessness, because that usually seen that in people who have a major depressive disorders, like right here. This one is feels of like worthlessness or hopelessness. All right, that's very important. And all of this excessive cry, there is also decrease doing activities. Doing activities. That's what it is. And not only people who have, let's just say, people who have normal grief have this. Sometimes people, when they lose someone, sometimes they tend to hear voices too, but that is not an hallucinations or not a psychosis. Sometimes this happens if the people are going with normal grief. All right, that is something that you have to remember. All right, hallucinate, like hearing voices and activity. And sometimes if you're going through normal grief, which usually resolve within 6 months, sometimes they tend to say that, let's say if you lose someone that you really love the most, let's say it's your wife, then sometimes you may say something like, I wish, I would be better off dead, something like that. Or maybe I wish, I could have died with you, stuff like that. But if that happens, you cannot do that as a clinical depression, all right? Because that is also normal grief process. But with the depression, the more extreme level, there's a suicidal ideation happen. There's more attempts. That also happens if the person have a major depressive disorder. It's very important you actually distinguish between the clinical depression versus normal grief versus the adjustment disorder too. It's very important. Now, after this, all right, let me quickly review what we talked about it, and then I'll talk a little bit about the pharmacology here. So in the trauma, stress-related disorders, we talked about the PTSD, and the PTSD happens with any sort of a traumatic or catastrophic event that takes place. It could be most often seen in rape and also the military combat or to the soldiers. But most commonly there, and that can trigger the hyperactivations of amygdala, and obviously also there's association with the cingulate gyrate. And usually, if you want to do with the diagnosis of the PTSD, the symptoms has to be involuntary, recurrent, and recollections with traumatic nightmares or flashbacks. And they also have symptoms avoidance, all right? At least these two, and that has to go at least for 1 month, okay? These symptoms has to be for more than 1 month. Now, with this hypervigilance, looking around, sleep disturbance, repetitive compulsions, fear and anger especially when they see the person, or let's say individuals, or the stimuli, or that. But if these problems are less than 1 month, then we call them a acute stress disorder. One more thing that you guys remember is that, for the prognosis of the PTSD and acute stress disorder is that, the onset, the time frame plays a very important role. If we able to get the quicker the onset, the better the prognosis, okay? That's what it is. And usually for the treatments, for let's say this PTSD, what they do? Number one is a group therapy. This is always very, very important, okay? Group therapy. And then the second option is you do SSRI. Why do we do a SSRI? SSRI we do is because SSRI is not to cure the person. SSRI is because their hyperactivity of these nervous systems is happening. So in order to reduce, in order to calm them down, in order to change this hyperactive, this behavior, we have to lower them down. So when they are calm, they can able to what? Communicate, or they can be more functional. That's why we give SSRI to those people. And because to cure is definitely a group therapy, because what we need to change is we need to change the cortical framing of their brain. We need to change the framing. We need to change that. And when we do all this kind of stuff, what happens is usually if the treatment is successful, one thing that it does is that you do see, this hyperactivity of temporal lobe you see, that reduces, that you see decrease in the hyperactivity of temporal lobe, the amygdala especially, and you see the increased activity of this cingulate gyri. And then remember, cingulate gyri has to do with what? Increase in alertness and concentration. It makes you feel a sense of security and safety. That's what it does. And it is obviously important for this emotional formation, processing and learning memory, and all of that. So it is very important that you should remember that. All right? Now, guys, I think this is all I have for you guys for now. Thank you. Keep watching. Thank you.